This is something new I came across, newer Canadian classification and its relevance in clinical practice. So, it has been noted that mortality in acute MI can be high as 10 to 15%, maybe more in our setup kind of thing. Hence, the situation of the STEMI is becoming essential to assess the benefits and potential risk of adverse events and to determine the intensive care, surveillance, and specific for medical and interventional therapy. Hence, a scoring system has been developed. So we have ECG, we have TIMI score, we have the heart score, and we have Cliff classification. However, these classifications do not take into account underlying myocardial tissue pathology. So the aim of this classification was to identify the tissue injury in MI, which is predictive of ventricular remodeling and adverse event such as heart failure, arrhythmia, hospitalization, and death. This classification also predicts the power of tissue damage for improving clinical research and beyond. So let us see what is this new classification. So what are the factors associated with faster progression? If you see on these various factors over here, we are very much aware of this. Any of these factors present will give you a maze which is not very good. Like for example, longer delay in reperfusion, longer duration of ischemia, Cliff classification, LAD territory versus non-LAD territory, larger deviation on ST, on admission ST deviations. Then rescue angioplasty, larger area of risk, and pre-procedural TIMI flow less than 3, post-procedural TIMI flow less than 3, and lack of collaterals. All this sort of leads to progression of this disease, and hence they have come out with this new kind of classification. So this is like a normal left ventricle. Then Canadian class 1 is like there's a formation of edema, or what they call it as aborted MI. Second is edema with cardiomyocyte necrosis. CCS3 is edema with cardiomyocyte necrosis with microvascular obstruction. And fourth, CCS4 is hemorrhagic infarction. So we'll go in detail about this this thing. So that's how schematically it's been represented. Is stage 1 is aborted MI. Stage 2, as I told you, MI with cardiomyocyte necrosis but no microvascular injury. Stage 3 is necrosis plus microvascular obstruction. And stage 4 is intramyocardial hemorrhage and plus leading to mechanical complications also. There's a pathological way of looking at it. Then first you see this normal myocardium, then you see this cardiomyocyte dysfunction. However, this whole thing is reversible at this point in time. Then once the necrosis and interstitial edema sets in, most of the viability is gone. Then this will lead to microvascular obstruction, and all this stage 2 onwards, most of the things are irreversible. And then stage 4 is it includes necrosis, edema, and then hemorrhagic complications and mechanical complications. So just going in details about stage 1, Canadian stage 1 aborted myocardial infarction. In our ECG wise, we see that more than 50% ST resolution at the end of 90 minutes of thrombolysis is successful or aborted infarction, what we call it as, plus or 30 minutes post PAMI with the absence of residual new pathological Q waves. So myocardial edema with absence of minimal cardiomyocyte necrosis, almost entirely reversible. If ischemia is not reversed at this stage, and this can go into stage 2, and then adverse events increase from 2-fold to 10-fold. So it's observed that more frequently with timely reperfusion, typically less 4 hours of ischemic symptoms, but most notably within 1 or 2 hours of onset of ischemia, which led to the term golden hour reperfusion, found to be more associated with pre-hospital fibrinolysis and has been very, very efficient. So this study incorporated, this study went on for many years, and they incorporated CMR in this kind of situation, late gadolinium enhancement, And then they found out this kind of situation where they demonstrated that myocardial edema can be seen, visualized, and hence they can sort of classify these patients and they can sort of give the prediction of their future events. So CCS2 is a cardiomyocyte necrosis without MVO. MVO is microvascular obstruction. So here the troponins are elevated. There is following reperfusion therapy, normal flow is restored and ST segment resolves. Echocardiography shows regional wall motion depending on the extent of myocardial injury, and if it is extensive, then it may end up having large permanent infarcts. So typically this myocyte necrosis occurs from subendocardium to transmural depending on the time of the reperfusion. So the concept is substantially clinical, with longer time to reperfusion leads to higher necrosis and then reflecting a larger myocardial infarct size. So infarct size is a strong predictor of adverse outcomes independent of LV dysfunction alone. So this is how the CMR revealed the presence of global left ventricular ejection fraction with mild hypokinesia of the anteroseptal and apical wall. So the CMR was being done and they demonstrated, and then the tissue sort of diagnosis was provided. Stage 3 is myocyte necrosis with microvascular obstruction. What we typically see in our patients who come late in presentation, where we see as a slow flow or no flow phenomena, and what we call it as a TIMI 1 or TIMI 2 flow. So these are typical of patients who are going into microvascular obstruction. So microvascular obstruction is independent predictors of adverse ventricular remodeling and independent predictor of MACE. They might identify patients with reduced tissue perfusion despite normal epicardial coronary flow after reperfusion. So this is again can be visualized in the CMR as microvascular obstruction, which is more pronounced with T2 weighted late enhancement, gadolinium enhancement. Stage 4 is fatal, which is hemorrhagic myocardial infarction, which can lead to mechanical complications like VSR, free wall rupture, and of course papillary muscle dysfunction. In addition to edema and necrosis, the ischemia is now set to affect the microvasculature and the integrity is compromised. Reperfusion into this necrotic microvascular bed drives extravasation of blood, defines hemorrhagic myocardial infarction. Hemorrhage occurs early after reperfusion, leads to infarct expansion, and this results in large infarction compared with stage 3. ST elevation may persist, and then it can lead to mechanical complications also. So this is a busy slide, but I want you to all concentrate the down part over here, how this hemorrhagic myocardial infarction behave. The cardiac troponins peak is earlier and higher. Hemorrhagic MIs expand following a wavefront pattern and are more transmural. Hemorrhagic infarcts are twofold larger, and they experience threefold progressive loss of salvageable myocardium. This is again a CMR picture showing intramyocardial hemorrhage and hypoenhancement on MRI. So this is again a busy slide, but I'll make it very simple. So stage 1 is reversible, and if you look at the last column over here, cardiac MRI, reversible wall motion abnormality, there's some edema over there. Stage 2 is what is called as classic MI. It's reversible on time, but most of the segments are irreversible over here, and wall motion edema is seen, and in the late enhancement of the CMR. Stage 3 is microvascular obstruction, and if you can see wall motion abnormality on the echo, edema, plus there is microvascular obstruction on the CMR, and stage 4 is hemorrhage, and that can be seen on T2 weighted gadolinium late enhancement. So what are the observations of this study is early initiation of reperfusion therapy along with shorter duration of ischemia can significantly reduce the likelihood of injury. Progressive loss of salvage of myocardium is associated with reduced functional recovery, worse LV function, and progressive increase in mortality, adverse event, including ventricular arrhythmias, heart failure, and hospitalization. So in fact, size, as I told you earlier, is a strong predictor even compared with independent of left ventricular dysfunction. So what are the implications and future opportunities of this paradigm shift therapies? It can risk stratify, it permits clinical grading of severity of cardiac injury and prognosis beyond common use markers like troponin levels, infarct size, left ventricular function, and to add to it, all those door to balloon time and all those things, it goes beyond that. The stage themselves could serve as a therapeutic targets. This classification takes into account the underlying tissue changes associated with MI and could be used as metric to monitor effectiveness of care delivery at health system levels. So what are the implications in clinical practice? This classification scheme allows for simplified understanding of pathophysiology. Clinical translation could help with risk stratification. This classification also clearly differentiates high risk from low risk. This might lead the groundwork for development of much needed cardioprotective therapies. Thank you for your attention.